Innate and adaptive immunity, but we will start first with innate immunity, inflammation, and wound healing. We gain innate immunity from the moment we're born. It's the first line of defense that we have against infection and other harmful substances. It provides immediate protection. And unlike adaptive immunity, which we will be looking into more closely later on in the presentation, innate immunity develops quickly, whereas adaptive immunity develops over time. Innate immunity is present from birth, and it doesn't require any prior exposure to a pathogen like that of adaptive immunity. It is activated automatically. It's natural, non-specific, but it still defends our bodies from a wide range of potential threats. And through our lives, our innate immunity works in conjunction with the adaptive immunity to provide this comprehensive protection against infection. Innate immunity is the body's first line of defense against infection and harmful substances. We just learned that. Now we're going to learn what we have within the innate system that helps with immunity. And we're going to start first with the physical barriers. Our body has physical barriers that help prevent the harmful substances from entering. Our skin, the largest organ, acts as a protective barrier, and it keeps bacteria out and viruses out. And we also have our mucous membranes that can be found in the respiratory tract, the digestive tract, and even the urinary tract as an example, and they trap pathogens and they prevent them from going deeper within our body. We also have chemical barriers. For example, enzymes in our tears, our saliva, our stomach acids, and they all help break down and kill bacteria as well. We also have antimicrobial peptides, and these are naturally occurring throughout our body, and they destroy a wide range of microorganisms. Now we're going to look at the cellular components that are bloodborne. We have phagocytes that include neutrophils, macrophages, and they recognize pathogens and they will ingest them. We have natural killer cells that can kill infected cells and certain types of tumor cells. We also have the inflammatory response, and so when a tissue is injured or infected, the body is going to automatically initiate an inflammatory response, and it's going to be characterized by the clinical manifestations of redness to the site, swelling, heat, even pain. And the purpose of inflammation is to help to increase the blood flow to that affected area. It's going to help deliver immune cells to the site of the infection and remove any harmful substances that shouldn't be there. There are inflammatory mediators such as histamine and cytokines, and they're released to promote inflammation. The complement system, this is a group of proteins in the blood, and the proteins enhance immune response by directly destroying the pathogens, by recruiting immune cells to the site of infection, and this is going to be through the process of phagocytosis. So in general, the innate immunity provides immediate, non-specific protection against a wide range of pathogens. It's rapid, while the adaptive immune system is more specific, it takes longer, and it needs to be activated. But both work together to help protect comprehensive attack on infections and to help maintain overall health. It's important for you as a student to understand the basics of both innate and adaptive immunity. Within innate immunity, recognizing inflammation, infection, and other immune-related conditions will be critical. Innate immunity being, again, the first line of defense against pathogens, the reaction is immediate and it's nonspecific. We're looking at now in depth the physical barriers that are tightly associated with the epithelial cells. Again, we can find them in the GI, GU, respiratory tracts. We looked at the chemical or the biochemical, lysosomes, defensins. And if you remember from biology, defensins are small cysteine-rich cationic proteins across the cellular life. It includes both vertebrate and invertebrate animals, plants and fungi. But for here in the immunity, we're thinking about how it affects, how the effects are seen in a human. And they host defense peptides which help to direct the antimicrobial activity, or thus immune signaling activity. Lysozymes, these are proteins that we find in the mucosa, our tears, saliva, or mucus, and they play the role in innate immunity by providing infection against bacteria, viruses, and fungi. In terms of the biochemical barriers, they are going to inhibit and destroy the pathogens because they can break down the bacterial cell walls and inhibit growth. The lower the temperature of the skin and the acidity of the skin, or the acidic pH of the skin and the stomach, this is going to create an inhospitable environment for many pathogens, and so it limits their ability to survive and to further multiply. Our body's normal bacterial flora homes a diverse population of microorganisms, and this natural microbiome, or the normal bacterial flora, has many benefits. These beneficial bacteria compete with other pathogens for nutrients and space, and so they hinder the ability to colonize and to cause infection. Our normal bacterial flora also produces chemicals and toxic proteins called bacteriocins, and they inhibit the growth and colonization of pathogenic microorganisms. So working together, the physical and the biochemical barriers, they're going to help prevent any entry and they will not allow the establishment of pathogens in our body. First line of defense, innate immunity, using physical barriers and normal bacteria flora. Now, some people call this the second line of defense, which is the inflammatory response. The first response to injury is inflammation. It's still nonspecific, and it can be caused by a variety of materials, such as infection. It can be caused by tissue necrosis, trauma, physical or chemical injury, foreign bodies, immune reactions, ischemia, etc. And you're looking for the local manifestations. Do you remember the local manifestations that we discussed earlier? Signs that we're looking for are redness, heat, swelling, pain, and even loss of function, depending on the degree of inflammation. This can be brought on by infection, mechanical damage, ischemia, nutrient deprivation, any type of high extremes in temperature, hot or cold, even radiation can cause an inflammatory response. We also will get a vascular response. In the vascular response, you will have blood vessel dilation, increased vascular permeability and leakage, and white blood cell adherence will occur to the inner walls of the vessels, and they will migrate through the other vessels. I want to draw your attention again to the local manifestations because I find it very important that we understand the cardinal signs of inflammation. And you can see them here also where they are derived from Latin terms: heat or calor, redness or rubor, swelling, tumor, and pain, dolor, and the last one being the loss of function. I want you to pay attention to the acute inflammatory response, and we're going to contrast that with the chronic inflammatory response in a little bit. But the acute inflammatory response, this is rapid, it's localized, and it protects the body's immune system to damage such as infection, and other forms of tissue damage within our body. It's crucial that we have this defense mechanism because we're looking for it to help to contain the damage at the site and to also help to eliminate that harmful stimuli. We want it to initiate the healing process. And we're going to look briefly now at what happens with the acute inflammatory response. So we start with the triggering event, or the inflammatory response itself being initiated by a triggering event. So what would that be? Maybe it's a physical injury or infection by a pathogen, or we were exposed to some type of toxin, or even our body having some type of autoimmune reaction. After the triggering event, we will start to see vasodilation and increased permeability of the blood vessels near the site of the injury. We'll see vasodilation, meaning that our vessels will dilate, and what happens is we're going to get increased blood flow to that affected area. What we will see in our patient is increased redness and warmth. Now, as the blood vessel walls become more permeable, then fluid will be allowed in, proteins, immune cells, they all start to move from the bloodstream and then now into the tissue. Then we have the recruitment of the immune cells. These cells, primarily, they're going to be the neutrophils and the macrophages. They're going to be attracted to the site of inflammation by chemical signals. They're going to be released by damaged cells and other immune cells. This process is called chemotaxis. The leukocytes then will be activated, and upon reaching this area of inflammation, these immune cells are going to adhere to the blood vessel walls. They're going to migrate into the tissue, and they're going to start to do this guided by chemical gradients. Neutrophils are the first immune cells to arrive, followed by macrophages. So if you wanted to see signs of early infection, you can look at the neutrophil count on a complete blood count with differential, which is a lab that you can get on your patient, which is a blood test. Next, phagocytosis, which is the destruction of the pathogen. The neutrophils and the macrophages are going to engulf and destroy the pathogens through this process of phagocytosis. They release enzymes and reactive oxygen species to kill and break down the invaders. Then we're going to have the release of the inflammatory mediators. These are various inflammatory mediators such as histamine, cytokines, chemokines, and prostaglandins, and they're all going to be released at the site of inflammation, and they all have a specific job. These mediators are going to amplify this immune response and attract, then by this amplification, they're going to attract more immune cells and increase the blood flow, increase the vasodilation, and thus we're going to have more localized swelling, pain, and heat. Now, next, we're looking for the resolution or the tissue repair. And so at the site of the infection, once it is controlled and the pathogens are cleared away, our immune response will gradually subside. The macrophages, they actually play a crucial role in clearing all the debris, and they're going to promote tissue repair. The new blood vessels are then formed, and then collagen is going to be deposited in the tissue to restore the damaged areas. Once the inflammatory response resolves and the affected area returns to its normal state, we have now left that acute inflammatory response phase. Still now talking about acute inflammation, I want to get just a little bit deeper now in that vascular response itself and to just review what is happening. So we have the blood vessel dilation, that's the first vascular response. So you're going to see redness and heat. Then we're going to see vascular permeability, which increases that leakage into the tissue from the blood. So what do we see in our patients? Edema and swelling. Leukocytosis occurs. So we can see an increase in WBCs knowing that the neutrophils are going to be first. We're going to see this increase happen on our blood count. We're going to have the increased numbers of circulating leukocytes. They're going to adhere to the walls of the vessels, and then they're going to migrate through those vessel walls. This then will trigger histamine, and histamine is a temporary reaction, but it causes something very rapidly, and that is the constriction of the larger blood vessels, and then conversely, the dilation of postcapillary venules. The endothelial cells will start to retract the capillaries, and it's going to increase vascular permeability. Leukocytes will be marginalized, and this process will all contribute to pain. Next, we'll see fever as a systemic manifestation of acute inflammation. Fever, also called pyrexia. This is a physiological response characterized by an elevation in our body temperature, usually 38 degrees Celsius or 100.4 degrees is what we would consider elevated body temperature fever, and this is defined as a rectal temperature. Now, it's often a sign of an underlying illness or infection. And most times when people get a fever, they go right for the Tylenol or the antipyretic to bring the fever down. But our fever actually is something physiologically there to help protect us. So first we have the trigger, whatever caused the pathogen, or in this case the pyrogen, to increase our body temp, and the substance that stimulated the hypothalamus, then the temperature will start to increase because our hypothalamus is that temperature regulating center within our brain. Now, pyrogens can also be endogenous, meaning that it can be something that was produced in our body, or it can be exogenous, meaning that it's a pathogen or a toxin. Then a hypothalamic reset will occur. Pyrogens act on the hypothalamus, on the preoptic area, and this controls the body temperature regulation. When the hypothalamus rises to the set point for the normal body temperature, the result is that the hypothalamus is going to perceive the body's temperature as being lower than the new set point, and then it initiates now an increase in temperature. Then our body goes through something called the cold phase. The hypothalamus temperature is going to reach this new elevated set point, and then it's going to enter the hot phase of fever. You think about this in terms of the body reducing the heat to conserve heat, or reducing the heat production, to be more specific, and this is going to conserve heat. During this hot phase, our blood vessels will dilate, and this causes that skin flushing to occur when we look a little bit more red, and heat loss starts to occur through the skin. And so if you've ever had a fever, and sometimes people will refer to this as breaking the fever, you start to sweat and your body is dissipating that heat through an evaporative cooling process. Now, let's think about the systemic effects. When fever triggers a systemic effect in our body, what's really occurring now is at the immune system level, the immune system is being activated. And this leads to an increased production and an increased release in the cytokines, and particularly interleukin 1 and interleukin 6. Tumor necrosis factor alpha can also be increased as well. Remembering that cytokines play a role in this inflammatory response will help you to understand the generation and the maintenance of fever. Then we finally get resolution. This is when the underlying cause, whether it was internal or external, or endogenous or exogenous, has been addressed. And then now the production of pyrogens will be decreased. The hypothalamus will gradually return to its normal set point. And then the body's temperature that regulates the mechanisms causing temps high and low will restore to the balance. And our temp will go down and our fever will be resolved. I just want to reiterate again that fever is a beneficial response and it assists in the human system, and it helps to fight infection because through fever it enhances that immune cell function. It inhibits the growth of certain pathogens. However, prolonged and very high fevers should be addressed quickly. They can be harmful. They need to be monitored. They can actually cause in young children and individuals with pre-existing medical conditions febrile seizures. In terms of the increased plasma protein synthesis that occurs, and we're talking about just within the acute phase, 10 to 40 hours, we'll get that maximum level of plasma protein synthesis. The complement components, the coagulation components will be triggered, and we can actually measure C-reactive protein. In addition to a WBC looking at the leukocytes or leukocytosis, we can monitor the progression and improvement of infection by obtaining a CRP on our patient, again standing for C-reactive protein. This CRP is produced by the liver in response to inflammation or infection or even some type of tissue injury or stress. And so we use CRP as a marker of inflammation and we measure it through the blood test. In the innate immune response, it binds to various molecules that are present on the surface of the bacteria, the fungi, or any damaged cell, and it promotes the recognition and removal by other immune cells. We can use this as a diagnostic marker because CRP levels will increase rapidly and significantly in response to inflammation. However, it's very nonspecific. We don't know what this inflammation means, but it will tell us or indicate the presence of inflammation, but no specificity. So we ask ourselves now, why are plasma proteins important? And we're going to go through the next few slides through the complement system, the coagulation, or also called the clotting system, and the Kinin system. And the plasma protein system, this is key to effective inflammatory response. And each of these systems consists of a family of proteins. That initial stimulus is going to cause some type of activation, and this activation is very sequential, and sometimes we call it a cascade of events or a complement cascade. All the systems contain inactive enzymes that get converted to active enzymes. So first proenzymes, then active enzymes. And substrates of the activated enzyme, they are going to become the next activated component in the series, therefore forming that cascade. So a brief look and panned out overview of these systems. We have here the complement system on the left, coagulation or clotting system in the middle, and the Kinin system. The complement system, we have proteins that attack the invaders. In the clotting system, we have extrinsic and intrinsic pathways, and it requires calcium for clotting. And we also need fibrinopeptide, or FP. And then the Kinin system, think of bradykinin, and bradykinin has histamine-like effects. So we'll go into a little bit more detail about each now. So looking at the complement system, it's important that we remember we are in the immune system. Actually, this complement system can be found, or part of the process of both the innate and the adaptive immune systems, and they are going to help to regulate our reactions. Let's look at in more detail. The complement system, these proteins are present in our blood. They're present in other body fluids as well. And they recognize and they eliminate pathogens by promoting inflammation, and they help to facilitate the clearing of the immune complexes. We will first get an activation of C3 and C5. And C3 actually is activated by C1 and C2. But let's just look at C3 and 5 for a second. The complement activation, or the cascade of reactions, once C3 is activated and C5 is activated, we're going to have some type of biological active fragment that helps to initiate the immune response. Looking now at opsonins in this activation of C3 and C5, what role does that play? Opsonins coat the surface of the pathogen, and it makes it more recognizable, and it can help trigger phagocytosis. We see that opsonins can be found on the fragments of C3b and C3-4. We also have chemotactic factors, and the complement activation will result in this release of the chemotactive factors such as C5a, and they attract immune cells, and particularly they're going to attract phagocytes to the site of inflammation, and they're going to help with aiding of the clearance of the pathogen. We also have anaphylaxitoxins, and they are activated within the complement system, again with C3a and C5a, and they induce the release of histamines from mast cells and basophils, and they promote inflammation, and they really contribute to the allergic reactions that we see with our immune system. There are 3 pathways, and we're going to look more closely at the classical and alternative, but I do want you to know generally that there are 3, and the lectin pathway is included. So the classic pathway, this is initiated by the binding of antibodies to a pathogen or pathogens. And while the alternative pathway can be activated more directly to certain surface structures of the pathogen, the lectin pathway is initiated by binding of specific proteins called lectins to carb molecules or carbohydrate molecules on the surface of pathogens. And each of these pathways, they lead to an activation of a complement component and then a subsequential generation of active fragments and diverse functions, and it cascades. The alternate pathway is activated by substances that are found on the surfaces of these microorganisms, like bacteria. We see them on the endotoxins, or for the yeast cell wall, enzymosins. They provide a rapid, immediate response to infection. And then this activation of the alternative pathway will then lead to C3. There's an C3 convertase enzyme. It's going to cleave to the complement component of 3 and to 3A and B fragments. With the classical pathway, this pathway, again talking about antibodies, this is going to be activated by the binding of these antibodies, and particularly it's immune globulin G, or we call it IgG, or immunoglobulin M, or IgM. And this is going to attach to antigens on the surface of the pathogens. That's a classical pathway. And this classical pathway is primarily involved in the adaptive immunity. So here you see that the complement system is actually part of both types innate and adaptive immunity, but the classic pathway is primarily involved in adaptive immunity. So with this classical pathway, we're going to lead to the formation of the C1 complex, which cleaves to C4 and C2. And that complement will generate that C3 convertase enzyme again. So again, we're getting to that C3. Now the lectin pathway is very similar to the classical pathway, but it doesn't require antibodies for activation. Instead, it's going to bind specific proteins or lectins to that carb molecule on the pathogen. Now we're going to look at the coagulation or the clotting system, which has an extrinsic and an intrinsic pathway. With the plasma protein systems or the coagulation clotting system, we see that our body has the ability to form a fibrinous meshwork, we call it, at the injured or inflamed site. And this meshwork is like a big net. It's going to keep the damage from progressing. And this meshwork is composed of insoluble proteins called fibrin. When fibrin formation occurs, we see that it's going to help with the clotting mechanism or coagulation because it's going to work directly at the injury or inflamed site. And the advantages are this: it keeps and limits the spread of the toxins because we get this physical barrier around the infectious agent, and then that meshwork is going to scaffold the migration of cells, including tissue repair and wound healing. And this fibrinous meshwork also contributes to the stabilization of that injured or inflamed site. And so this is going to prevent further damage from occurring at that site. This fibrinous meshwork also will promote the clearance of cellular debris and any waste products that are in the way and shouldn't be there. Now we're going to define, what does this mean, extrinsic pathway or intrinsic pathway. Extrinsic pathway, this is initiated by the release of tissue factor or TF. And this release is going to be from damaged cells or damaged tissue. This TF will form a complex with another clotting factor 7. And this leads to the activation of a cascade or sequential ordering of events of clotting factors. Ultimately, when it culminates together, it's going to convert fibrinogen into fibrin. With the intrinsic pathway, this is going to be activated when blood comes into contact with certain surfaces such as collagen that could be found in a damaged blood vessel. And the pathway involves a series of clotting factors that will interact and lead to the formation of fibrin. Both intrinsic and extrinsic pathways, they converge at a common pathway. And the commonality is where the enzyme thrombin is generated. Thrombin cleaves to fibrinogen, which again, remembering this is a soluble protein, and it cleaves it into fibrin strands. And when this occurs, this stabilizes the fibrin meshwork. And you can see the video link provided as a visual representation of what this blood clotting process looks like in more detail. Again, really stressing that this is an insoluble protein. We get fibrin at the inflamed site. It creates this fibrinogenous clot, stops the bleeding. The microorganisms and foreign bodies are limited to that area. And this is going to be that framework to keep on moving towards a resolution of inflammation in that area. It's going to stop the bleed. What is going to stop the bleed? What is this meshwork anyways? The meshwork fibrin is going to trap blood cells, it's going to trap platelets, it's going to trap plasma from forming a clot. And this is going, it's going to trap plasma and it's going to form a clot. And this is going to help to stop the bleeding because you have the clotting. We do have a localized inflammatory response because this fibrin clot is going to make sure that nothing else is going to penetrate or be damaged by creating that physical barrier. What's the role of calcium in the coagulation system? This is important to understand. These calcium ions are essential for the clotting system in order for it to function properly because they participate in the activation of the clotting factors and they help with the conversion of fibrinogen into fibrin, which is, again, an insoluble protein. The presence of calcium ions is going to help to ensure that we have a stable fibrin clot. I also want to bring up EDTA, which is an anticoagulant. This anticoagulant binds to calcium and it prevents their involvement in the clotting system. And so whenever we get a purple top, as far as a lab tube, it has EDTA in it, which is being used as that anticoagulant. And this helps to keep the blood in a liquid state. It helps it to not clot while we're transporting it to lab and when it's being tested in the lab. And it also requires that we have plasma or whole blood samples. So in summary, the formation of the fibrin clot at the injured site is going to be essential for us in terms of being able to stop the bleeding and localize the inflammatory response. That framework is going to help to repair and to heal. We need calcium ions because this is going to help with the clotting system. It's not going to work properly without calcium. EDTA is going to prevent clotting to occur, and we use this in blood tubes so that we can essentially buy ourselves more time before our specimen clots. Okay. Let's look again at the intrinsic and intrinsic pathway. The intrinsic pathway, remember, this is contact activation. Extrinsic is tissue factor pathway. And with the extrinsic pathway, it's faster and it's shorter. It's a faster and shorter way to get to blood coagulation. With the activation of tissue factor being released, the damage when it gets exposed in the tissue area and tissue factor moves into this area, we have proteins that are present in the tissue outside of the blood vessel. Tissue factor is also known as factor 3, by the way. And when it binds with the coagulating factor 7, we're going to form a complex known as the tissue factor 7A complex. Okay, so this is a little bit more detailed than I'm going to need you to know for my quiz, but I do want you to understand the movement or the cascade of events that occur. Once this happens, we also have the activation of factor 10. And this is when the factor 7A complement will activate the factor 10 to become active into factor 10A. Now in the common pathway, factor 10A joins in the pathway of coagulation, and this is going to help with the fibrin clot. In the intrinsic pathway, we know that this is more complex. It takes longer for blood to coagulate, and it's initiated within the blood itself, and that's why it's called intrinsic. So it's usually in response to some type of endothelial damage or exposure to a foreign surface. Lastly, we're going to look at the Kinin system. Again, remembering that bradykinin has a histamine-like effect, which increases permeability. This Kinin system interacts very closely with the coagulation system, and the actions of kinins are actually to help with vasodilation, increased vascular permeability, pain sensation, and then lastly, it helps to activate mast cells. So with vasodilation, bradykinin causes the dilation of blood vessels, which leads to an increased blood flow to the affected area. This is going to help deliver immune cells and nutrients to the site of inflammation and infection. It's going to increase that vascular permeability by allowing fluid and immune cells to enter the surrounding tissues. So we see the inflammatory response here again. And this is going to help, the inflammatory response is going to help the immune cell recruitment to occur. In terms of pain sensation, kinins can stimulate nerve endings, and so this results in the perception of pain when the kinin system is activated, and this is in response to inflammation or injury. When mast cells get activated by the kinin, they're being activated by additional inflammatory mediators such as histamine and cytokines. So this all happens within the kinin system. By the way, with the pain sensation, it's the prostaglandins that will induce that pain. We talked a lot about cytokines and mast cells, and additionally, I just want to get into a little bit more detail in case you forgot in biology what cytokines are. They're messengers in our bodies, and cytokine comes from a word meaning cyto, so cell, and kines, that is derived from where we get our word for kinesthesia or kinesthetic, so movement. And so these messengers are moving throughout our body to help the immune system talk to the different cells that are all over the place. They're tiny proteins that are made by the immune cells. So when there's infection or when our body needs to defend itself, cytokines are put out. So think about your immune system, in terms of having a bunch of defenders protecting the body. And whenever there's a sense that there is an invader, intruder, or a pathogen, they send out these messengers, or cytokines, and they're going to communicate with the other cells. They give signals and instructions to the other immune cells, telling them where to go, how to fight. Think about in terms of, bacteria or viruses being a pathogen entering our body. Our body will understand that there's been an invasion, and the cytokines are going to go and tell the rest of the immune system what to do. Once the body is able to defeat the pathogen, then the cytokines will then go out, again, being a messenger. They're going to tell the immune system that it's time to calm down, it's time to go back to equilibrium or a normal state. So we want to really make sure that the cytokine levels throughout our body are at a balance. Otherwise, it can cause problems, not being able to activate the immune system or not being able to tell the immune system to stop because the invader has been attacked. Well, think about cytokines in terms of how they act. We can think about the autocrine action, which is auto meaning it's going to affect itself. And so this is when they act on the cell that produced them. So when a specific immune cell releases the cytokine, that cytokine is going to bind to the receptor of that immune cell or that own cell surface, and this is going to lead to the cellular response. So this helps to regulate activation, proliferation, and differentiation of that immune cell. Whereas the paracrine action, this is when cytokines act on nearby cells, and this is going to help, it's trying to help mediate activation of things within the microenvironment around it immediately. And so the immune cells are going to release the cytokine into the extracellular space, and then it's going to diffuse, but it's only going to diffuse into the nearby or neighboring cells. And this is going to produce different immune cells and other types of cells to respond to that cytokine and initiate their appropriate immune response. Whereas the endocrine action, this is when they are released into the bloodstream, but then they act on distant targeted cells throughout the body, much like endocrine effects. So it's not anything nearby or neighboring, it's going out into the bloodstream. Once it reaches that target cell, which is located in a different organ or a different tissue, we can now have an immune response. And the cytokines will elicit specific responses to these cells, and they don't have to be immune cells with this type of action. They can also be non-immune cells, but we're going to have some type of immune and physiological reaction. So again, cytokines, they're diverse. They affect immune cells and other types of cells in our body. They can stimulate immune cell activation, proliferation, differentiation, and also promote immune responses against certain pathogens. They regulate inflammation. They modulate the balance between a pro-inflammatory and an anti-inflammatory response. And some cytokines actually enhance the recruitment and activation of immune cells to the site of infection or inflammation. If you like to see things more grouped up or in under different classifications, you can use this chart here to help to understand, well, which cytokines are the ones that do certain things. So it's divided within the function. And if you want to see between the structural classifications and then according to the division of labor, you can use this chart to look at more detail. But we're going to look at specific cytokines now. The first one being the chemokine. And chemokines, they induce chemotaxis. And this is when they signal molecules that play vital roles in regulating the immune responses by maintaining that homeostasis in the body. And with chemokines, they will regulate the migration and activation of immune cells. Their role is through inflammation, immune cell recruitment, and the organization of the immune responses. They're going to attract specific immune cell types to the infection. They're more specific. Chemotaxis, think of a taxi, they're moving things to where they need to go. Now the interleukins, these are a group of cytokines that are primarily produced by immune cells. So think about like lymphocytes or macrophages. And they're going to regulate the growth, the differentiation, and the activation of these immune cells. So in terms of lymphocytes, like the T cells and the B cells and natural killer cells. So some examples of interleukins are interleukin 1, 2, 6, 10, 12. They all have a specific function in the immune regulation. Tumor necrosis factors, specifically tumor necrosis factor A, these are going to be involved in the host defense and tissue remodeling, also the pathogenesis of inflammatory disease. And then lastly here, interferons. These are cytokines that have an antiviral, immunomodulatory, and anti-proliferatory effect. And they are released in response to a viral infection, and they help control viral replication and spread. So some of these examples would be interferon alpha, interferon beta, interferon gamma. So always viral responses. This chart also helps you to maybe see it better or in a different way that maybe your brain understands it. You can see which ones actually produce vasodilation versus vascular permeability versus pain. You can also see it in terms of systemic effects, like which cytokines are responsible for fever or leukocytosis or something that occurs in the acute phase. Then you can also look and say, well, which cytokines limit inflammation, which are part of the immune response, and which are involved with repair, healing, and phagocytosis. So this is how you use this chart to get a little bit more detail here. Now, mast cells, they're also sometimes called professional phagocytes. These are a type of white blood cells that contain numerous granules, and you can see them in the darker bluish purple, the little granules, and they're located in the loose connective tissues, very close to the blood vessels. And they become activated once there is some type of physical injury, chemical agent, or some type of immunological process that occurs. These mediators are released in the extracellular environment during mast cell degranulation. And so we will see histamine, serotonin, ATP, lysosomal enzymes. We also will see eicosanoids, and we're going to talk about those in a little bit in more detail. Mast cells, these special cells that are located in our body, they're like little defenders that can be found throughout, and they help to protect us from allergens and infection. And just imagine this mast cells all over. They're all over our body. They're just ready to go to fight for us. And they can be found in our skin, our lung tissue, our GI, our GU tissue, and they have special sensors on the surface. And so when they detect something harmful, particularly an allergen or some type of bacterial or viral germ, it's going to enter our body, and the mast cells will sense this. Once they sense this, they're going to release histamine. And histamine, it's kind of a love-hate relationship. It's going to cause different reactions in our body, like itching, redness, and swelling, but it's because it wants to defend our body. But unfortunately, these symptoms are very irritating to our patients and sometimes harmful. Think about mast cells in terms of being the alarm that lets our immune system know, like, hey, something's not right. We need to help send out the message and get other immune cells to come and help fight this invader. Let's delve into now the factors and mechanisms that are involved in mast cell proliferation. So we have stem cell factors or IgE-mediated activations. And the IgE-mediated activation, this process leads to mast cell proliferation, and it promotes this very amplified allergic reaction. And this is why we will look at IgE specifically when we have a patient going through an allergic response to see if it's an IgE-mediated activation that is occurring, that's causing the signs and symptoms of allergies. And it also helps us to see if it's a other type of pathogen as well. We also know that cytokines and growth factors can influence mast cell production, and the microenvironment itself can influence the proliferation. For instance, factors such as tissue injury, inflammation, exposure to substances can also trigger mast cell proliferation, and this is all regulated with other interactions by our immune cells and the components of these immune cells within the extracellular matrix. So let me just summarize that little bit. Mast cell proliferation is complex, but it's regulated by these various factors like stem cell factor IgE, activation, cytokines, growth factors, and the microenvironment. It's looking at the cues within these things to know if it needs to proliferate further. So we need to understand the pathogenesis of allergic and inflammatory diseases. When we have excessive mast cell proliferation and activation, this is going to contribute to things like asthma or allergic rhinitis, so allergies. But conversely, if we target mast cell proliferation, if scientists are able to do this more effectively, they can offer therapeutic opportunities for controlling these reactions. And we've done this through our certain medications that help with allergies and asthma. But future research is ongoing, it's needed. It's going to help us to create even more targeted approaches for mast cell related disorders. Mast cell degranulation, we're going to get into now a little bit more detail. This is a process in which the mast cell itself, which again, it's an immune cell, the stored granules that it has, how does it release those granules or degranulation? And so when the mast cell encounters some type of stimuli and it undergoes degranulation, we have a very rapid release of these granules from the cytoplasm of the mast cell into the surrounding tissue or the bloodstream. This is essential. It's essential in definitely allergic reactions, but it also has some responsibility in non-allergic inflammatory reactions as well. So we're going to look now in terms of triggers for mast cell degranulation and what occurs. So if it's an allergen, we know that mast cells are going to play a role in allergic response. And so these allergens, such as pollen or dust, dust mites, and even certain foods, the mast cell is going to recognize this and say, oh, no, it's an allergen. I'm going to release some granules. These granules also release, at the same time, we're also releasing histamine from the mast cell. And that's where we get this very allergic response. We also have immunoglobulin E or IgE, and these antibodies are produced by the immune system in response to an allergen. And so this is all through the B pathway or the B cell pathway, which we're going to see in the adaptive immunity slides. IgE will bind to the mast cell, which is going to sensitize that specific allergen. And so that when the allergen later interacts with the IgE bound to the mast cells, we're going to have degranulation occurring. So with degranulation, again, we're going to have histamine causing vascular effects. We're also going to have chemotactic factors such as neutrophils and eosinophils moving in, attracting these immune cells to come and help. The physical factors, certain physical stimuli can cause mast cell degranulation as well. And so this can lead to conditions like physical conditions like urticaria, which is a fancy word for hives. We can also make this occur when there's high exposures to heat or cold, pressure, even vibration can prompt some type of mast cell activation and cause degranulation. When mediators that contribute to degranulation are seen, we have allergic reactions, itching, swelling, redness. We can also have bronchoconstriction and increased mucus production as clinical manifestations within our patient populations. And so really understanding how mast cell degranulation occurs and its role in various immune responses, this is going to help us to better manage the allergic disorders that some of our patients suffer with, or autoimmune conditions, and even the inflammatory diseases. In terms of mast cell synthesis, we talked about the mediators. Prostaglandins, these are eicosanoids that or are produced through an enzymatic conversion of arachidonic acid, and it plays a role in the inflammation because it promotes vasodilation, vascular permeability, pain, and recruitment of more immune cells through the process of chemotaxis. Prostaglandins, they're synthesized by the COX enzymes. So non-steroidal anti-inflammatory drugs, or NSAIDs, such as aspirin, they actually inhibit this activity of the COX enzyme, and this leads to reducing prostaglandin synthesis, and so therefore reducing pain. Now, leukotrienes are another example, and they're also derived from arachidonic acid, and they primarily are being released from mast cell membranes. They're slower, they have a more prolonged effect, however, compared to histamine, and they also play a crucial role in the later stages of inflammation. Leukotrienes will contribute to increased vascular permeability, smooth muscle contraction, so bronchoconstriction can also occur, and again, the recruitment of more inflammatory cells. Then we have the platelet activating factors, or the PAFs, and PAFs are lipid mediators, and they act on platelets. Very similar to leukotrienes, they activate and promote platelet aggregation. And they share some similarities with prostaglandins and leukotrienes in terms of its effect on vascular permeability and chemotaxis of the immune cell, and the induction of the inflammatory response. So what you would see is that PAFs, they are produced by various cell types like platelets, leukocytes, endothelial cells, and immune cells. So why do we need to understand these functions? Because these mediators are needed if we're going to have any type of therapeutic approach to managing the inflammatory disorder. For instance, like we just saw, that if we didn't understand the COX enzyme and knowing that NSAIDs actually block that synthesis of prostaglandin, we wouldn't really understand how NSAIDs work to reduce pain. The same thing with leukotrienes. We actually use leukotriene inhibitors with asthma to help decrease the effects of vascular permeability and chemotaxis of the immune system. So we're trying to decrease that occurrence of immune response. And if you wanted to see how this looks in terms of the synthesis of eicosanoid, you can. I'm not going to test you on this, but it is really important to understand that these molecules play this important role in our body, and we need the molecules of eicosanoids and eicosanoid synthesis to occur in order to have that full immune response. Remembering just generally that eicosanoids, they help our body to respond to the injuries and to the infections. How do they help? They send messages to the different parts of our body to help with the healing and the protection. And so sometimes when there's too much inflammation, or if the eicosanoids aren't balanced, it can cause allergies and other things to occur, certain diseases as well. So we have to make sure that the balance of this proliferation and the synthesis is happening at a rate that our bodies can handle, so that these messengers can help heal and protect. We're still in the innate immunity pathway, looking at now how our blood-borne components are responsible for some of this innate immunity actions to pathogens, and how they recognize infectious agents and respond to cytokines. So let's do a quick overview starting with erythrocytes or red blood cells. They are the most common, they're abundant in the blood, they contain a hemoglobin, which is protein, and this is the oxygen carrying component that allows oxygen to move to the lungs and other body tissues and organs. The main function is oxygen transportation. Red blood cells typically have a lifespan of 120 days. They're produced in the bone marrow, whereas white blood cells or leukocytes, they are more diverse. There's more different types of white blood cells, and they play crucial roles in the immune system as well. We have neutrophils, lymphocytes, monocytes that turn or mature, eosinophils, basophils. They all have a unique function in the immune system as well. Neutrophils are the most abundant type that are involved in phagocytosis, which is engulfing or destroying the pathogen. Lymphocytes include T cells and B cells, and this will help with the cell-mediated immunity, which we're going to talk more about in adaptive immunity. And then monocytes, which mature into macrophages when they reach the site of infection, also involved in phagocytosis and antigen presentation. And then lastly, the platelets or thrombocytes. Remember, they're small, they're crucial for blood clotting and wound healing. We're going to see how they contribute to our innate immune response. First, looking at neutrophils, we also call them polymorphonuclear leukocytes, PMNs, and they are more predominant in the early inflammatory responses. So if we get a very high neutrophil count, we might think that we are just in the beginning stages of inflammation. They can ingest bacteria and dead cells and cellular debris. And so when we're looking at something or an infection and at the site there's pus or purulent exudate, this is neutrophils. It's because they only live 1 to 2 days in the tissue. Monocytes maturing to macrophages at the site of inflammation, being first produced in the bone marrow itself and then circulated. They will develop into a macrophage when they migrate to the inflammatory site. I said this a few times. I think it's really important to understand that progression. They typically will be seen at the inflammatory site about 24 hours later after our neutrophils get there. I realized that I forgot to define the process of phagocytosis, and this is when cells ingest and dispose foreign materials. So there's 4 steps. There's recognition, adherence, engulfment, fusion, and destruction. And so I'll just talk about that a little bit more, and then we'll get into eosinophils and platelets. So with recognition and adherence, the phagocytic cells, they have receptors on the surface, and they recognize and bind to the specific molecules on the surface of the foreign material pathogen. This recognition is then facilitated by opsonins, and we've heard this word a few times now. They make the pathogen look tasty. They are proteins that are going to coat and target, making it easier for the phagocytes to be recognized, and so that our phagocytic cells can bind to them. Once the receptors on the phagocyte know the target or recognize the target, they're going to undergo adherence or attachment. And this is when they are tightly bound to the foreign material. But it's not until the next step, engulfment, once that occurs, that the pathogen is actually engulfed inside of the phagocytic cell. And so a phagosome will be formed. So adherence, the phagocyte extends its finger-like projections or pseudopodia, and then they surround that material. Then the finger-like projections or pseudopodia fuse together. Then they form a phagosome. A phagosome is a membrane-bound vesicle that contains engulfed material now. The phagosome, when it fuses with lysosomes in the next stage, which is fusion, it forms you guessed it, a phagosome. And this is a membrane-bound organelle containing the digestive enzymes. then the lysosomal enzymes within the phagocytomes, they will break down and destroy the engulfed material. So they're digesting it. And then these enzymes are going to be ready for destruction and digestion. The phagocytome, or this engulfed material, is going to be subjecting itself to enzymatic degradation. The lysosome will break down the material. They're being digested. And then finally, it's going to be released into the cytoplasm of that phagocyte, and they're going to be processed even further and eliminated through exocytosis. So we do need phagocytosis. It's very critical in defending ourselves, our bodies, and the immune system. And it's essential for having a robust immune response in our overall health. All right, so going back now to eosinophils. Eosinophils are only mildly phagocytic. Though they're capable of phagocytosis, the activity is low compared to macrophages or neutrophils. They can ingest and remove antigen antibody immune complexes from the bloodstream and cause an allergic reaction. So when we think of eosinophils, or whenever eosinophils are present, predominantly we're going to have some type of allergic reaction in response to an allergen, so pollen, dust, dander, or even an allergic reaction to food. In allergic reactions, eosinophils are recruited to that site of inflammation, and they're going to release inflammatory mediators and cytokines. They also can be present to defend against parasites. Eosinophils are important in the defense against parasitic infections. They're going to be stimulated by immune mechanisms such as IgE-mediated hypersensitivity reactions. And the eosinophils are going to become activated and then therefore attack the parasite. They're going to release toxins, and they are going to cause neurotoxins to be released, and this is going to damage and kill the parasite. We also have attacks by IgE-mediated hypersensitivity reactions in vitro. And what this means is that the eosinophils are going to be induced to attack parasites when it's being exposed. And once the IgE antibody binds to the surface of the eosinophil, it's going to trigger this activation and release the toxic substance. So this is the in vitro induction. Platelets, also called thrombocytes, they are produced in the bone marrow from a megakaryocyte, and they circulate in the blood. Their normal count is about 150 to 450,000 per microliter. Once they are lower than 50,000 per microliter, we call this thrombocytopenia. They are at risk for excessive bleeding. And then if there are too many platelets, thrombocytosis, this will increase the risk of excessive clotting. So why do we need platelets? Because they need to help stop the bleeding. And they're linked to three processes: adhesion, activation, and aggregation. And adhesion is initiated when there is a loss at the endothelial cell level. Activation of platelets leads to a shape change. And once this shape change occurs at the glycoprotein receptor site, or integrin, at the platelet surface, then the fibrinogen and the von Willebrand factor, VWF, will be essential for this aggregation and clot formation. And then lastly, aggregation, which is basically the platelet plug. It becomes stabilized because platelets begin sticking together. They form this plug at the site of injury or wherever there's vascular damage, and they're going to help stop the bleeding, stabilize the clot, and really important part of this process. And if you like it in picture form, you can also use this here as well to help guide your understanding of platelet adhesion, activation, and aggregation. Now we're going to talk about the stress response. really quickly. As nursing students, it's really important to understand the stress response that's actually occurring in your body as you're going through nursing school. First, our body perceives the stress stimulus. Once it understands that there is something stressful happening, whether externally or internally, it is going to activate the hypothalamus. The hypothalamus, that regulates various types of bodily functions, is going to send a signal to the pituitary gland. It's going to recruit that pituitary gland to release a hormone called ACTH, which is also called adrenocorticotropic hormone. It's going to be released into the bloodstream, which then stimulates the adrenal gland. And the adrenal gland is the small glands that are located on each kidney that releases the stress hormone or glucocorticoid called cortisol. Excuse me. So this is why this is called the HPA axis. The hypothalamus recruits the pituitary gland, releases ACTH, recruits the adrenal glands that releases cortisol. So when cortisol levels are up, we understand we are stressed out. Cortisol is a key hormone involved in this stress response. Cortisol has multiple effects on the body. It can increase our blood sugar. It can enhance the breakdown of fats and proteins for energy. It suppresses our non-essential functions like digestion and even our immune response. So it puts us at greater risk for infection. And also, because it suppresses digestion, we can also have issues with constipation and elimination. Now, the sympathetic nervous system also becomes activated once cortisol is released. And the stress response that activates the SNS, or this cortisol release, will then release a neurotransmitter called norepinephrine. And when norepinephrine acts on our organs, this is what causes, in the SNS, increased heart rate, elevated blood pressure, dilated airways, and it redirects blood flow to the muscles. So what are the physiological changes that could occur? With the combination of cortisol and the SNS being activated, we can see increased alertness, heightened perception, our focus improves, we have more muscle strength and endurance, and also it can decrease our pain sensitivity during this physiological change of stress. And these changes can help us to be more responsive and adaptive to the perceived stressor. But there's also feedback regulation that occurs. When the stressor is no longer present, then that feedback loop is going to tell our body we need to restore homeostasis. So the hypothalamus is going to say, yep, there has been a decrease in stress hormone, so then I will further inhibit the release of ACTH, which is going to decrease cortisol production from the adrenal glands. Then the parasympathetic nervous system is going to counteract what the sympathetic nervous system was doing, and this is going to allow the body to return to a more relaxed state. Chronic or excessive activation of the stress response can have an overall negative effect on our body, and so including cardiovascular disease, immune dysregulation, and mental health issues. We can also have impaired cognitive function. So try to do your best as a nursing student not to be too stressed out, because it does affect our cognitive abilities as well. One more thing that I want to talk about, I did, with neutrophils, and we talked about leukocytosis occurring, and when pus becomes produced and we have purulent exudate. Pus is just a large number of leukocytes that are persistent in an area, and it tells us that there's something going on. There's persistent bacterial infection. With the hemorrhagic exudate, this means that there's blood in the area and it indicates bleeding. When we use the term fibrinous exudate, this is exudate that contains fibrin. So when we're looking at it, it looks like a thick clotted exudate, and so we know that there's more severe or advanced inflammation. We use the term serous exudate to signify anything that looks a little bit more watery, and this is early or mild inflammation. We're now moving on to our chronic inflammatory response. You can see here that already looking back at acute inflammatory response, there are some different things happening with the chronic inflammatory response. So chronic meaning there has been some persistence of infection, antigen or foreign body. And we can see what happens with neutrophils, lymphocytes, fibroblasts, and inflammation. We're going to start with just defining what is chronic. Chronic inflammation is anything that lasts 2 weeks or longer. It is an infiltration of primarily a mononuclear lymphocyte, and we have monocytes or more mature macrophages that are involved with chronic inflammatory responses as well. A granuloma is going to be formed by macrophages. Remembering, macrophages are only mature once they get to the inflammatory response. These mature macrophages are going to turn and form a granuloma, which is going to attempt to isolate the infected area or wall off this area of infection. Often, a chronic inflammatory response is due to persistent infection or antigen or foreign body, something that we cannot eradicate. However, there may not always be a previous acute inflammation that moved into a chronic inflammatory response. So think in terms of TB, leprosy, syphilis. You might not ever see anything acute. It just jumps right into a chronic inflammatory response. So chronic inflammatory response, again, it doesn't stop when the harmful stimuli has been removed or resolved. It just leads to this persistent long-term inflammation. Many factors are involved: autoimmune disorders, chronic infections, exposure and repeat exposures to toxins, maybe even poor lifestyle habits can also contribute to chronic inflammatory responses. Systemically, we can see that there's going to be tissue damage. It's going to disrupt the normal cell functions. It's going to lead to a whole wide range of health problems. Chronic inflammation has also been linked to many chronic diseases such as diabetes and heart disease, cancer, autoimmune disease, and even neurodegenerative diseases. Clinical manifestations that you might see: fatigue, fever, joint pain, loss of appetite. So more general type clinical manifestations. So make sure you understand what you might see an acute inflammatory response versus a chronic inflammatory response. Diagnosis and treatment of chronic inflammation is usually based on symptoms, getting a good medical history, and physical exam. We can also use CRP to measure inflammation. We talked about that protein or C-reactive protein blood marker. And we can treat chronic inflammation depending on what the underlying cause was in the first place. So treatments might include medicine, lifestyle changes, dietary modifications, but it's all based on whether or not there was acute phase or what the most up-to-date treatment is for this chronic inflammatory response. We need to find out what is causing it. Here is a lymphocyte here showing that there is some type of inflammatory response because there's a foreign body in the area. This is what it would look like histologically. And you can also see that we have Langerhans or giant cells that are noticeable on histology with chronic inflammatory responses as well. So we're going to look more closely now. We know that we're trying to get to the regeneration and repair of tissue during these type of responses, but what is regeneration? That is defined as the replacement of any damaged tissue with new healthy tissue. And so think about your skin, new epithelium. Sometimes though we have a compensatory or physiological response. think about the liver. We have hyperplasia that occurs, but it's trying to regenerate healthy tissue. Repair, when we talk about that, this is when a destroyed area is repaired with scar tissue. And scar tissue is primarily collagen. And what the collagen does is it helps to restore the tensile strength of that tissue prior to the insults. And this can also take up to 2 years in some cases. And we're going to see the phases of wound healing, which are going to be important to understand. And there are 3 intentions: a primary, secondary, and tertiary intentions. And so we're going to get a chance to look at the different steps of wound healing, starting with coagulation, inflammation, and moving down. So let's just look first at hemostasis. This is when we have just the initial phase of wound healing, and it's right after the injury occurs. And the main goal is to let's stop the bleeding, let's form some type of clot, and make sure that we have some constriction to reduce the blood flow to that area. That way platelets can come and form that clot and seal out that wound. That clot now is going to help to provide a temporary barrier, and will lay down the framework for the next phase. So also called the coagulation phase. Okay, so hemostasis or coagulation. The inflammatory phase, in this phase, the body initiates some type of inflammatory response to remove the debris, fight off the potential infection. So think white blood cells, especially neutrophils and macrophages. They're going to attack the wound site, and they're going to remove the bacteria and foreign particles. While the macrophages will clean up the debris and release the chemical signals to initiate the next phase, which is the proliferation phase. And the proliferative phase, this is when we have new tissue. So during this phase, the new tissue is going to replace that damaged tissue, and the wound will start to fill in with granulation tissue, that mix of new blood vessels, new collagen, and other supporting structures of that tissue. Fibroblast, which is a type of cell that produces collagen, will help to provide strength and structure to that healing area. Epithelial cells at the wound edges will start to multiply and migrate, and this is what's covering the wound, and it reduces the risk of infection. And then lastly, we have the maturation phase, which is the final phase of remodeling, and it is the strengthening of the new tissue. Collagen fibers are going to rearrange themselves and become more organized here now. We're going to have increased wound strength. And the blood vessels that were formed in the proliferatory phase or proliferative phase are going to start to now regress. And what happens? The scar is left behind. That scar tissue will gradually remodel and become stronger and stronger over time, but it might not ever regain the same strength as the original tissue. So we know that overall, the wound healing is dynamic. It's this overlapping process of each of these phases, and it really relies on the previous phase to get done correctly to set the foundation for the next phase. So wound healing is done by different intentions. We have the primary intention, which is typical for uncomplicated surgical wounds. And this is where we'll see that the wound edges will approximate together, and sometimes we might even need sutures or staples with primary intention wound healing. What we hope to see is that the connective tissue will start to be deposited, and epithelialization, when the epithelial cells will come together, will start to occur, and this is what promotes the healing. And these wounds usually heal pretty quickly, and hopefully there's no infection. So that's primary intention. Versus a secondary intention, the wound's left open and healing will occur very gradually. And we have granulation tissue forming, and the contraction of the wound edges first, and then subsequently the epithelialization of the tissue. The wound will show some type of delayed healing because of the volume of connective tissue that needs to be healed and required to fill the defect. Since there's no epidermal barrier, that risk of infection is significantly higher in these wounds as opposed to the primary intention wounds. Wound healing by secondary intention is typical for chronic wounds such as venous stasis, leg ulcers. We would see this type of healing process. Wound healing by tertiary intention, it's very delayed. The primary closure takes a long time, and sometimes it's necessary to actually go in and to help. And so think about abdominal incisions. You'd have to go in and do an abdominoplasty. It's going to take a while for this type of wound to heal. And so if you left the wound open for several days, this is going to help the formation of granulation tissue, and then the wound edges are going to be stitched together. This is a second procedure. By doing it this way, it will help to lower the risk of infection. Now, unfortunately, even if you have the ability for wound healing, primary, secondary, tertiary intention, sometimes wound healing can be dysfunctional because of lack of nutrients. Not enough oxygen, not enough glucose, not enough protein. Or there's excessive bleeding at the site. Too much fibrin can cause fibrous adhesions. And so if you ever heard of someone say there's adhesions on the organ, maybe they had some surgical procedure done and the two organs actually adhere together. Obesity can decrease the ability of your body to heal infection, and certain medications can also make wound healing more difficult. Steroids, NSAIDs, and some anti-neoplastic drugs. If there is dysfunctional wound healing, what you might see on the outside is dysfunctional collagen synthesis. So you might see a hypertrophic scar. Hypertrophic scars can be erythematous, pruritic, so very itchy. They are raised lesions. Keloids, which you can see on the lower photo, they will extend beyond the borders of that original wound. Something also that can happen, unfortunately, is dehiscence of the wound. And we use that term when we're talking about when a wound actually pulls apart at the suture line. And this can happen when there's excessive strain on that area, or if there's infection, or even obesity can cause dehiscence. So that's the end of the first part of immunity, talking about innate immunity. The next presentation we'll talk about adaptive immunity, which is the third line of defense.